Calicut. So today our topic for panel discussion is potpourri of common adolescent problems. Dr. Rajiv Seth and Dr. Chendil have kept the platform ready for us. It was very, very interesting and also made us think in the direction of this panel discussion and gave lot of vital informations. As we all know, adolescent population in India is the maximum in the world. So we have about 253 million adolescents living in our country, which is almost 20% of our population. And as pediatricians, we are the first point of care for every adolescent in this country. So it is vital for us to not only treat them for physical ailments, but take every opportunity to understand them better and probe into their psychosocial aspect as well, which will be the key message from every case we are going to see today. 75% of the mental health problems in adolescence begin during adolescence, whether it is substance abuse or anxiety, depression, or lifestyle problems. All of them have their origin during adolescence. So it is important and vital to have sufficient knowledge to deal with them and also get skilled to counsel them in most situations and treat them accordingly. Coming to the psychosocial aspect of every adolescent, these are the major risk factors which pose them a great trouble, which can be managing their own emotions because of the pubertal changes, developing an identity crisis is a big challenge here, resisting peer pressure when it comes to harmful or self-harm behaviors, and building strong relationships among themselves as well as with their family, colleagues, and society. And most importantly, they have to acquire life skills which will help them a long way in their career and their balanced life later. And this is the stepping stone for getting into their education and set a career for themselves. As Dr. Chendil said, it is important for every pediatrician to focus on psychosocial history. As you will see, most of the diagnosis in adolescence is through history and a little on physical examination. So it is vital that we not only take regular history like any other child, but we spend little more time on psychosocial assessment, that is through this HEADS platform, which is easy to do in our OPD, where we can have printouts of this. We can give it to the adolescent children as they are waiting. It takes about 5 to 7 minutes for them to fill it up before they enter the chamber. In that way, we will be able to give anticipatory guidance wherever we foresee a problem. Now, with this introduction, we move to the clinical case scenarios. The first child is a 15-year-old boy, Shivesh, who was brought by his mother with complaints of being withdrawn from family and at school from his friends, behavioral changes, sleep and appetite issues for the past 6 months. Can I ask Dr. Lakshmi to take this?
Yeah. Thank you, Dr. Jayasri. At the outset, I would like to thank the organizers for this wonderful extravaganza, academic extravaganza, the entire organizing team of Sangamam Pedicon, and a special mention to yesterday's sumptuous Onam Sadhya. It really deserves a really big appreciation. Okay, so coming to the case scenario, actually, adolescent practice is very interesting in the fact that we see the children we have seen as small babies since birth. We give them vaccination and well child clinics, and after a gap of like 5 to 6 years, they disappear from our clinics only to come back after like 5 to 10 years as all grown up adolescents. It's even difficult to recognize them because they're all grown up and well built. At the same time, it gives a subtle hint that you are getting older. So that is how adolescent practice is very interesting. So coming to this boy, Sivesh, he has been my patient since he was a baby. And so suddenly, as I said, he came all grown up as an adolescent. And as told by his mother, he had these behavioral issues. So I insisted on a proper heads assessment. So I took time to ask all about his lifestyle, starting from the home, eating habits, all those things. And he later revealed that he was bullied in his school because he had this gynecomastia, or what these boys call as man boobs. So this after that, I just made a clinical examination starting from head to foot, because we know that gynecomastia can also be secondary due to the hormonal things, but there was no abnormality. In fact, he even resisted in removing his shirt. So such distressed are these adolescents that they don't even want to remove their shirts in front of someone or in a public. And his mother also told that whenever they go for a tour and when he goes to a swimming pool, so he doesn't even remove his shirt. So such was his level of distress. And after coaxing him and doing a breast examination, it revealed glandular tissue and fat. And his BMI was in the overweight category. So now coming to gynecomastia, it's a very common thing that we all see, but we don't look beyond the gynecomastia. So we just see it as a sign or a part of obesity in adolescents, but we don't see the behavioral aspect behind the gynecomastia. So prevalence is about 4% in males aged 10 to 19 years. It's physiological. Actually, gynecomastia has three peaks. The first one is in the neonatal period. We all know it because of the transplacental passage of the estrogen hormone. The second peak is in adolescence, and the third peak is in the older age due to other reasons. So this pubertal gynecomastia is physiological, commonly seen in Tanner stage 3 to 4. It's due to an imbalance in the androgen-estrogen ratio. It's almost self-limited in 75 to 90% of the boys, and it regresses over 1 to 3 years. Pathological gynecomastia is very rare and is related to estrogen excess, which may be due to exogenous. Here we have to be very careful in taking the history, because these adolescents are very prone to use many substances or muscle to improve their muscle growth and all those things. And these supplements and protein shakes or some other things can contain a very minor amount of estrogens in the form of plant estrogens or phytoestrogens. So we have to be very careful in taking the history in such cases. So that is the exogenous or endogenous estrogen, or it may be due to an androgen deficiency or androgen insensitivity. And another one important reason is the increased peripheral conversion of androgen to estrogen, especially in obese adolescents. So this is the picture depicting the fat tissue and the glandular tissue. So in obese adolescents, only the fat is more. Okay, so coming back to our adolescent boy Sivesh, so I just gave him a counseling on lifestyle management, body weight control, and I chose to wait and reassure him for another 1 year. But this boy, after 1 year, he came back with similar complaints, and he also said that it's giving him a significant psychosocial distress. So I just referred him to a plastics after ruling out the endocrine causes of gynecomastia. So finally, this boy at 16 and a half years, he underwent a surgery with a plastic surgeon, and he had the removal of breast tissue by liposuction and glandular reduction. So this is the grading which needs surgery. We have two types of gradings. It's mostly for surgeons, but as pediatricians, it's enough that if we remember that any excess of breast tissue in a male, so usually the nipple is 20 centimeters from the sternal notch in an adolescent boy, and the nipple areolar complex, which we call the NAC, is 28 millimeters of average size. So whenever there is an increase in the nipple areolar complex more than 2.8 to 3 centimeters, we call it gynecomastia, and we actually wait and watch. But if it doesn't regress over 1 to 3 years, or if there is an intractable breast pain or tenderness, then we need to opt for surgery. So this patient actually underwent surgery and is doing good now.
Thank you so much. So what is the take-home message from this? Gynecomastia is often cause for psychosocial stress in adolescents. Even we know even acne is not a simple problem in adolescents. So we can think of gynecomastia. This is going to cause a huge psychosocial impact on them. But yet we have to remember that, as Dr. Lakshmi said, 85 to 90% of them are only pubertal. So all they need is reassurance from a pediatrician, but we have to be very clear and assertive about that. At the same time, we also adjust their lifestyle. In this case, as you saw, obesity has to be brought down. and usually this declines over the next 2 to 3 years. However, we have to take all the steps to rule out any other underlying endocrine causes by plotting simple growth charts, by seeing whether the child is short statured or the child has any clues for other endocrine problems like hyperthyroidism, hypogonadism, and so on. So again, thorough history, including drug history, is very, very important. As we are aware, many drugs can cause gynecomastia. And the last word, please beware of lotions, creams, and herbal powders. Many of them contain phytoestrogens. So applying them repeatedly and massaging in the body, which adolescents tend to do, can also pose a risk for gynecomastia. So with this, we move to the next case scenario. Shreya, a 12-year-old girl, was brought by her mother, who seemed concerned for a recent bedwetting problem and abnormal behavior since a few weeks. Can I request Dr. Ranjith to take this?
Thank you. Honor greetings to all of you from IAP Kerala, and thank you IAP Tamil Nadu and Sangam Padikon team for this great conference and opportunity. So we are moving to the second case, that is Shreya, 12 years, was brought by her mother, who seemed concerned about her recent problem, that is bedwetting problem and abnormal behavior since few weeks. And in the class teacher also complained about she had some indifference in classroom activities and she felt nervous during the class time. And Shreya was uncomfortable during the interrogation, and on examination we felt we fought an erythema in the perineum. So as in all adolescent, that is psychosocial assessment, we had done the heads assessment. So in the heads assessment, the significance points are, and there is, she is staying with her parents using a single room. There is no family conflicts. Recently, one of her cousins staying with their family for higher education purpose and education and activities, and there is no addictions. She is not in a relationship. And adolescents, we know, they are not open to the conversation. They are open to the clinicians or counselors during the frequent visits. After her second individual child-friendly, adolescent-friendly session, Shreya revealed something unexpected. And she revealed that she had unpleasant sexual experience with her cousin who is staying with them, and which she don't want to remember. And flashes of that incident make her uncomfortable during her studies, and his presence in home make her really uncomfortable. So the hurdles the adolescents pediatrician or pediatricians facing is that we have to express the feelings, we have to ventilate out the feelings by the child. And adolescents usually fears the doctors and they are uncomfortable with the doctors, especially pediatricians or any other doctors, and they have unbearable anxiety of the stress, and they have painful memories, they have post-traumatic stress disorders. Majority way seems depressed also. So next hurdle for the adolescent pediatrician is the revealing the fact to the parents. So as the perpetrator from the same family, we have to very careful while disclosing to the parents, and there will be chance of distorted family milieu, and there will be chance of defamation through social media and media. And in the previous session, Rajiv says sir mentioned about POXO. So we have to aware about the responsibilities by the pediatrician. We have to report it, and we have to report it to the police also. So the useful tools for venting out these issues, we have to have a separate time for the adolescents. We have to be patient, and we have to listen to the adolescents carefully, and we have to maintain the utmost privacy and confidentiality in the issues. And as pediatricians and pediatricians caring adolescents, we should acquire a basic counseling skills, and we have to make it like a storytelling. We have to ask them to like a storytelling. If they are not comfortable, they are not aware of the sexual education, we have to show them some pictorial charts and assess child sexual abuse. We have to draw ask them to draw diagrams, and we have to make them aware of the activities with toys also. We can ask them to draw pictures, and we have to identify the indicators of sexual abuse. Then the child may present with physical symptoms and signs which were not there before, and there may be worsening of symptoms. There will be worsening of obsessive compulsive disorder, there will be chance of post-traumatic stress disorder, there will be unusual fear, and they lost interest in the previously fun-filled activities. There will be academic backlog. There may be chance of bullying and aggression, and they may show high-risk behaviors. They lose vigor in their activities. Chance of substance abuse as they are succumb to sexual abuse also. And there may be sleep disturbances. They may feel irritable. They may feel depressed. They may feel aloofness. They have suicidal ideation also. And they show some discomfort in the presence of certain adults and objects, which will be an indicator of child sexual abuse. So many a times it will be the sexual abuse history is concealed also. So we should make our adolescent and children, we should teach them about the safe touch, unsafe touch, confusing touch. We know the only safe touch is the shake hands and the touch which the adolescent or child feel uncomfortable. It is a confusing touch or unsafe touch. And we should management, we should have a detailed record keeping. We should have an informed consent. We should report to the police and medical treatment as per the severity of the child sexual abuse. We should do investigation. We should do the screening, HIV, HBsAg, and we should start drugs according to prevent the sexually transmitted diseases. And we should give psychological support to the child and to the parents also. And we have to empower the parents about sexuality education. We should refer to a counselor or psychiatrist if needed. So the best way is sexuality education is the earlier years is the best way to prevent sexual abuse. So, and we should make the child to understand that no one has the right to indecently touch you without your permission.
Thank you, Dr. Ranjith. So it tells us that child sex abuse is not a disease or a disorder. It is a complex state of affairs. It remains with him or her throughout the life. It is a traumatizing experience. And when I say him or her, we have to remember that boys are also equally abused as girls. Most of the time, we only tend to talk to girls about this. And when we meet a child who has gone through this child sex abuse, the response from the child can be secrecy, followed by helpless feeling, accommodation, disclosure, and then recantation. They can retract their statement, as Dr. Rajiv said. So as primary pediatricians who come across these children, it is our duty to talk to them with empathy in such a way that they will be able to come out of this distressing experience. And also, we play a great role in anticipatory guidance through schools and various programs by which we can get a platform to meet the adolescents. And we have to remember, we have to report every child sex abuse child to POCSO. Now we move to case scenario 3. A 13-year-old girl brought to clinic by parents complaining of deteriorating academics, anger problems, undesirable social contacts, and excessive internet usage. Can I request Dr. Jeya to take this?
Thank you, Dr. Jayasri. This is a very important problem with our adolescents now, internet usage. But before going on to the case, there's just one thing I would like to alert the pediatricians to. We talk about adolescent mobile addiction, adolescent internet usage, but what we see now is we have children as young as 2 or 3 who are addicted to the mobile. You know, they come to the OP. When I say, no, you can't use your mobile there, they throw a tantrum, they throw things, they pinch and beat their parents. So we have to start tracing them much earlier. With that, I'll go on to my case. She, as Dr. Jayasri said, 13-year-old girl who was actually brought to the clinic not for counseling, so I couldn't do a heads assessment initially. Mother said she's being very, very difficult, and she just wanted me to counsel her. So subsequently, I did a heads assessment on her, and she was a student in a private, high-end English medium school. She comes from a nuclear family. Her mother is a teacher in a Tamil medium school, and father is a retired government employee. The parents are elderly parents, and she confessed that she didn't have any physical activity. All the time she spent after school was on her mobile, and mother said that the moment she didn't have a mobile of her own, she had been demanding for one, but the moment mother came back from her work, the girl just took the mobile from her and went upstairs to her room, locked herself up, and whatever the mother might have to say, there was no reaction from her. She wouldn't even come down properly for her dinner. So recently, mother also felt, and she said that she had plenty of friends on social media, Snapchat, mostly elderly boys, older boys from low socioeconomic with criminal antecedents. A price scale was done, which has a maximum score of 72. So as you can see, she scored very high on it, indicating a very severe degree of dependence. This scale is for problematic risky internet usage screening scale. It was developed in 2014 for adolescents and young adults. It has 18 components and three subscales of emotional problems, social problems, and risky or impulsive internet usage. So the score was high, but the one thing which I thought left her with some hope was she had some insight into her severe degree of internet usage, and she was kind of willing to look into the problem. She was arrogant, defiant, rude to parents, very demanding, and I asked her about whether she had any suicidal thoughts, and she was very. I was very surprised that she came. No, I don't have any in, suicidal intents, but I do threaten my mother with suicide if she doesn't do what I need. Like, for instance, she was demanding an iPhone, and if she didn't get that, she would threaten. But she didn't have any serious suicidal intents. Clinical examination revealed no abnormality. Thyroid function, hemogram were normal. This is a sample of the price scale. This is available for downloading from internet. Very useful. So internet addiction, there are a lot of factors which encourage internet addiction, especially in adolescents, teenagers. They have very limited coping skills. So they start using internet to deal with their stress, and they need to express their own identity. They go through a lot of identity crisis. Most of them don't know what they are, so they start by mimicking the peer group, and that is a major problem here. She comes from a very middle socioeconomic background. She's been put in a high end school where her peers all have the latest gadgets, and so she thought she had to keep up with them. She went into this, and that's how she got into this network. And we see that in internet addiction, children start off with this sort of usage. Eventually, they find it as a modality for bullying, harassing other children, youngsters. What we find is they get a dopamine surge. They from the ego boosting effect of the likes and all the encouragement they get from their social media friends, and they find their parents very inadequate. They expect them to encourage them, expect them to go into superlatives about even a little achievement like scoring a good marks in school. And when that doesn't come, the parents are classified as very discouraging, and their friends as the encouraging good people. This is from the psychiatrist. This gives a idea about the neuropsychological chain, how they get into this vicious circle. So we have a basic tendency, a primitive drive, which leads us to usage of something which reduces our stress. This with a combined drive, which is peer pressure, leads them to internet usage. And once they go there, like I said, it is very rewarding for them. They get euphoric. They experience a feel good factor there, which makes them addicted to it, and they become dependent to the usage, and they become tolerant. So if we try to intervene at this point, and if we try to reduce their internet usage or get them off it, they go in for um uh, reaction. Is just as bad as withdrawal symptoms which we experience in drug abuse. So even if we manage to get them to reduce and they go in for passive coping, what happens is that primitive ideas and their peer pressure makes them go back to internet usage. So what are the consequences? What do we do? If we just leave them, what happens? They demand up-to-date devices, and they threaten parents with suicide, and the academics suffer because they have lack of focus. They even refuse to go to school. All they need is is a mobile phone. They get into bad company through internet. They progress to personal contact with these uh, uh, low socioeconomic people. She can even, especially girls, she can even put herself at risk of abuse from the so-called friends. So we need to counsel them at an early stage, Uh, and with counseling, we aim to produce a gradual reduction in internet time. We can't say no, you can't use the internet at all. We just have to be very, very careful about how we get them gradually into that. And for that, we need to get them to engage in other interesting activities, which the parents and the mother, the mother, the parents, and the teachers have to help us through this. So the pediatrician, parents, teachers have a role. So how do we approach such a case? As I've already done, the prize was done. It is part of DSM-5 as well now. We have to communicate with the teenager, counsel on serious consequences, get to them very, very gently. You don't say, no, 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 you stop using the internet, which will only make them very defiant. Parental counseling is very important because parents play a very big role in getting the teenager out of this. You have to motivate the teenager with articles from papers, magazines, and real life stories. And the most important thing is you have to set realistic goals. Neither the parents nor the teenager nor we should think that, oh, we can just cure all this with a wave of a magic wand. We set realistic goals and work towards it, encourage alternate activities, monitor the internet time. So you just tell them, okay, you can use the internet, but for a specific period, and make it reward oriented. You finish your homework, do whatever work you need to do, and then you can go on the internet for a specified period of time.
Thank you. So we understand that this child has a complex problem. It has to have a multidisciplinary approach. So internet, we are all caught in this web, and internet gaming disorder has been included in DSM-5. And the simple definition would be a persistent desire and an unsuccessful attempt to control the urge or cut back or discontinue internet use. So here we need to combine with psychotherapist, psychiatrist, and repeated counseling sessions, and also teach them there are better ways of getting this dopamine surge. After all, we have so many other healthy ways of getting the dopamine surge rather than using internet. And anticipatory guidance is where pediatricians play a great role. There is a role for pharmacotherapy in small number of children. If they have an underlying anxiety or depression, we treat that. And if they have any neurodevelopmental disorders like ADHD, then we treat them. And opioid receptor antagonists like naltrexone have been used by psychiatrists when it is very resistant or difficult even after repeated counseling. Now we move to case number 4. A 17-year-old girl, Vidhi, was brought by parents with history of headache on and off for the past 3 months. Headache is always a dilemma for pediatricians because we have differential diagnosis from top to bottom. So we have Dr. Lakshmi to answer this.
So this girl Vidhi was another one of my teenage patients. She was a very bubbly child almost till she was in 8th, 9th standard. She was good in academics. She was good in singing. She was a good all-rounder. But as she stepped into 10th and 11th grades, she was a bit, drawn to like more of problems. That's what her mother revealed. And this headache, so when there are behavioral issues, parents are not much concerned until it is very pressing need to come to the doctor. But when there is a physical symptom like headache, they immediately come because they think that that is something very problematic. So when she was brought with headache on and off for the past 3 months, on a heads assessment, I found out that she also had some appetite, sleep issues, and I could even find her very, when she was sitting in front of me, she looked very tense and fidgety. And her mother also revealed that she developed some low grade fever, especially during the tests or some grading exams. And because this headache was there for the past 3 months, I just want to make a basic assessment like a routine blood test. And since her mother was a hypothyroid, I know the patient since a childhood, so I just did a thyroid profile, which was normal. And in the heads assessment, she's a second born of working parents. Elder sibling has cleared NEET and in first year of medical college. And I found out that the heads assessment starts from the home. And for this poor girl, the home environment was the most very tense or very stressful environment, because she was being constantly compared to her brother, and her parental expectations were also very high. But basically, she's an arts person, good in singing, drawing, and she's won many school competitions. and she wanted to take up commerce but influenced by parents to take up computers and join BE. This we have seen in many households lately, and she also tries hard to keep up in studies but in vain. So now we have a 17-year-old girl with headache for the past 3 months. Otherwise, no other physical complaints. So starting from the history, we find the characteristics, the severity of the headache. We had a very nice session on headache on Friday. So we just start from the basic thing like characteristic. What are the triggers? Because we know that some food items can trigger the headaches, especially the common migraine and even tension headaches, and any aura or associated symptom, any medications which may relieve the headache, family history of migraine and other comorbidities. And we need to look at the other aspects like if she has any symptoms of anxiety or depression, any stressors. For example, this girl had fever during the tests. So that has to be a stressor. And any diet or sleep modifications which she had, and media use and substance use. On an examination, uh, recording blood pressure recording the blood pressure for every adolescent who walks into our clinic is a must. And especially today we are seeing many obese adolescents and those even in metabolic syndrome like children. So recording BP is a must. Head circumference to rule out other causes, growth centiles, BMI, all the routine investigations what we do. So after doing all this, we come to a conclusion like we just look at if there are any red flag signs, which I'll come to later. If there are red flag signs, then immediately we get a diagnosis of secondary headache, which will go into imaging and investigation. If there are no red flag signs and if we find comorbidities in heads assessment, then if it is positive, it's mostly a psychological headache. If it's not there, then we can move on to a classification of migraine or other primary headaches. For this girl, we found that she scored positive in the heads assessment, and the headache was more of a psychological origin. So, what are the red flag signs in adolescent headache? Early morning headache or vomiting, awaking the patient from sleep, recent onset of severe headache, change in quality or frequency, occipital headache, but we also have sometimes migraine can also present as occipital headache, and progressive headache increasing in severity. We ask the child to rate the headache on a scale of 1 to 10. The severity, if it is increasing, then we need to look at other diagnosis. And not responding to conventional therapy, if there are seizures or systemic symptoms, changes in personality, behavior, or worsening school performance, and abnormal growth, puberty, or neurological findings, which gives us some clue to other causes, and hypertension. So on further assessment, actually I gave this girl initially a course of NSAIDs and for 2 weeks, and gave her some basic counseling and anticipatory guidance, and asked her to come after 2 weeks. And after 2 weeks when she came, she felt a little better with the headache symptoms, but she said she feels very stressed, and she's not able to sleep properly and things like that. So I thought I would do the PHQ4, which is a very simple screening tool for both anxiety and depression. It has 4 questions. The first two questions are for anxiety, and the third and fourth are for depression. The first one simply we ask the girl whether she feels anxious, tense, and all that. And the second one is we ask her whether she has these worrying thoughts, whether she is able to control her thoughts. For these first two questions, she scored positive, like she scored 5, and which is suggestive of a anxiety disorder. It is only a screening tool. So this is a basic simple tool we can use in office practice. If she scores positive, then we can go to the other tools like our SCAD tool and GAD7 and things like that. So anxiety disorders is one of the most common internalizing problems encountered in children and adolescents. Fear, worries, and anxiety form the spectrum. So it could be a simple fear for an exam or for a subject. For example, most of them have a fear for math. So it could be a simple fear. If it gets more, then it becomes a worry. If you can't control that worry, then it becomes an anxiety. So this is the spectrum of anxiety disorders. Well, fear and worries are normal human emotions. Anxiety is a feeling of worry, nervousness, and unease about something with an uncertain. It is simply, put it in simple words, irrational fear. Irrational fear is anxiety. And according to the latest statistics, about 1 in 10 children suffer from any one of the anxiety disorders before they turn. And this is the classification of anxiety disorders. So every one of us, not only the adolescents, every one of us here, we experience the fight or the flight response in response to our basic lifestyle, whatever we challenges we face in everyday life or in certain special situations. So these anxious children also experience physical symptoms like palpitation, abdominal pain, nausea, headache, excessive perspiration and muscle tension. So this fight or flight response determines whether a child or an adolescent will go and develop an anxiety disorder, or whether she is resilient and she is able to control her worries, and then she develops a self-esteem. So this is what determines whether a child goes into anxiety. So coming to the management, so the main part of management is child and parent psychoeducation, because here we found that the parenting was also a bit on the wrong side. They were expecting her to score high and select a different thing. So here the parent counseling was also very important. And anxiety can be graded into mild, moderate, severe. Mild and moderate cases can be managed with positive behavioral therapy and psychological therapy like relaxation techniques, cognitive behavioral therapy, exposure therapy, and mindfulness based therapies. But severe anxiety, which is determined by the scared tool, a score of like more than, if the score is more, then we go on for medications. And I think we have to get a psychiatry opinion before starting on the medication.
Thank you. To sum up here, as pediatricians, we have to be cautious before labeling anxiety or depression as the cause for headache. We have a whole lot of psychosomatic symptoms. They can mimic organic disorders. A child with anxiety can present with dyspnea, breathlessness, mimicking an acute asthma attack, or with palpitation, sweating, which can mimic a underlying cardiac problem, or they can present like hyperthyroidism, where they have again excessive sweating and increased heart rate. They can mimic migraine many a times, and many neurological symptoms as well. So it is imperative that we understand there are lots of differential diagnoses which can mimic anxiety. And second thing, we should not be scared in administering these screening tools to every adolescent. So as Dr. Lakshmi said, this screening tools may look very scary because they have too many items, but the Psychiatric Society have come out with patient health questionnaire which have 3 or 4 items to just screen them initially when they are waiting. If it comes positive, then we can go on to administer the elaborate scale like this one, which is called the childhood anxiety related disorder screening tool. So it not only helps us to make a diagnosis of anxiety confidently and then get a help of a specialist and treat this child, but also it helps us to understand what kind of environment makes them anxious, whether it is the school, or is it generalized, or it is fear of crowd, or it can be separation and so on. So it is important for us to have these screening tools in our clinical practice so that we can administer them in appropriate situations. Moving on to case number 5. Rahul, 16 years, was a bright student till last year. This year his academic performance is worsening. He spends a lot of time with friends whom parents hardly know. Can I request Dr. Ranjith to take this?
So we are going to the history of Rahul, and further inquiry, Rahul's mother says that he often comes late recently and prefers to left alone. His taste of clothes and music has changed recently, and he gets disproportionately angry when questioned about pocket money. So we felt that something unusual happened to the Rahul. So heads assessment, and he is staying with parents using a single room. There is no family conflicts earlier. Now he had frequent conflicts with the family members, and he prefers to stay alone. And education, he is academically brilliant, A grades in all subjects, and there is an academic decline for the last 6 months. And he was active in sports also. He was school's cricket captain. Now not interested in sports. So after the individual adolescent friendly third session only, he had revealed that he started using some substance with friends. And initially he got it free from friends. Now he needs money to purchase the same. So that is the frequent inquiry for the increase in pocket money. So we have to identify, we have to educate the parents, and we have to identify the indicators of substance abuse. There are 3 indicators, mainly physical, psychosocial, and academic. Physical, we know that the child prefers to stay alone and they use toilet, extra toilet usage. They use toilet for the using substance, and they use snuffles. They use deodorant to mask the symptoms of uh, signs of substance abuse. They felt some of them appears red eyes. They have some hoarseness of voice. They look blank stares are there. There will be needle tracks in the body. And psychosocial, they had recently changed the peer groups. They had frequent mood swings. They show high risk behaviors and high risk driving, and they had increasing conflicts with the parents, and they avoid hug with the parents and peers, and they have shows poor hygiene. Decrease the they have decreased sleep habits, and they started stealing money. And there may be academic, there will be blacklisting, there may be falling grades. They show drowsiness in the classes, they show inattention in the classes, and they had frequent absenteeism in the school. So we had to identify the indicators of substance abuse during the interrogation. Next. And evolution of substance abuse, we know that initially the substance abuse start with supari or be something. It may start by 8 to 10 years, and it is often neglected by the parents or teachers, and gradually they change to tobacco. And tobacco, we know it is usually equated as being grown up, and pan beetle chewing also common in some of the communities. And beer and wine, it usually first consumed with the peers, and other forms of liquor which is consumed when away from the home. So we know the substance addiction drugs are the serious forms of addiction. So it is also on the rise. So what is the management of substance abuse? We can identify the drug substance with some questionnaires like craft questionnaire, which is available in the internet, and S2BI questionnaire, which is also available in the internet. We can screen them based on the substance, based on these questionnaires. So management of substance abuse, the main aim is prevention is the principal aim, and we have to educate the parents and children in the school age itself before explore and experiment. And we have to discuss openly with the consequence with the kids, and we have to check the history with the peer groups, and we have to identify the early indicators. And as parents and teachers, they have to monitor the finance vigilantly, and we have to get professional help as early as possible. We have to get help from adolescent pediatricians and any excess department if needed. Most of them need psychiatric help also. We have to rule out the psychiatric disorders, and if they are improving after the treatment, we have to praise any slightest improved behaviors and encourage them to involve in the family function, and encourage into them to get involved in the sports and cultural activities also. So parents are the best clinicians at home. We have to, prevention is the principal aim.
So please be aware that many a times normal adolescents can also give vacant stare to parents. They wear a lot of perfumes, and also they visit toilet frequently to stay away from parents. Let us not diagnose substance abuse on every one of them. So we have to follow this diagnostic criteria and look for other telltale signs, both physical as well as mental changes. As pediatricians, we always give great importance to nutrition. We tell them often that what food you eat, you are that. So you are what you eat. Now, in these days, when we talk to every adolescent, we have to remind them, you are what you take. So much so, substance abuse is on the rise, and it causes lot of physical problems starting from brain to every other organ, and also mental health challenges which can have an impact on the society. And this substance abuse are mostly illicit drugs, because alcohol and tobacco are easily available. But illicit drugs, which require a lot of money, is also on the rise. And the symptoms usually progress from experimentation to recreation to problematic and then addiction. And through school health programs, we will be able to encourage them to take healthy lifestyle and stay positive. And just one or two words about school performance, because in all these case scenarios we saw there is a decline in school performance. So there are physical, we have to first evaluate a child whether they have any micronutrient deficiency, anemia, then get into the psychosocial history, we will be able to get a reason, and puberty and peer related issues, and finally the substance abuse and addiction also we have to keep in mind when we evaluate a child with academic deterioration. So step 1 will be to get a detailed medical history and evaluate the sense organs. Second will be to rule out emotional, social, cultural and environmental causes. And please do a comprehensive education assessment, which is very possible by every pediatrician, to just make them read, write and check their basic skills, which will give us an idea for disease disorders like SLD, specific learning disability, and also have assessments if needed for neurodevelopmental disorders. The last case, if we have 2 minutes, ma'am. Yeah. Please be fast. A 14-year-old girl was brought with history of excessive weight gain and short stature.
Thank you, Dr. Jayasri. We'll go through it quite quickly because I think we've dealt with adolescent obesity. She had excessive weight gain, short stature, menarche 13 years, oligomenorrhea. There is reduced physical activity. And what is more significant here is pre-COVID, she was, that is in 2018, she was 49 kilograms. Now she's gained so much weight, she's 72 kilograms. And the other significant finding is that she's 140 centimeters height for this weight. So we look for other causes of obesity and short stature. Her karyotyping revealed that she was a Turner. So this is the thing that we have a double trouble here. When you have an adolescent with obesity, I think we should also look on to other factors, especially the height was a pointer here that there might be some other factor involved. And adolescent obesity evaluation, it could be endocrine metabolic, but I think the commonest is a lifestyle problem. So about 80% is that, the rest of it is metabolic, but we should always be on the lookout for a pathological cause like a delay in growth, puberty, dysmorphism, hyperphagia, any visual symptoms, neurological features. And red flag signs, if they have a height less than 3rd centile, delayed bone age, hypoplastic genitalia, menstrual problems, severe hypertension, all point towards pathology. Obesity in adolescent, as we all know, we've all been going through this, especially post-COVID. And causes, it could be dietary excess, inadequate physical activity, and the social media overuse. And what is the impact? It causes hypertension, coronary artery disease, osteoarthritic problems, sleep apnea. And management, prevention is the main thing. Because once it goes on to this stage, it is very difficult to get them to cooperate to our management programs. So, but anyway, we have to motivate them, set goals. And the goals, again, should be very realistic goals. You have to tell them that just because you start dieting and you start doing exercise, you're not going to lose 10 kilograms in the next 2 weeks. Because most of the adolescents turn up saying, oh, I've dieted, I have done a lot of exercise, and I haven't lost any weight. So motivate them, set goals. And adolescent obesity is a practical nightmare, not just because it is a cosmetic problem, but there are likely endocrine problems. And it is very important that we screen them with BP, BMI, waist circumference, and blood tests. And we should have a very low threshold to investigate the obese adolescents.
Thank you, doctor. So the cues for pathological obesity will be visual problems, hyperphagia pointing to some syndromes, short stature with obesity, like in this case, the girl turned out to be a mosaic Turner. That is why she did not have the classical features of Turners, delayed or absent puberty, neurological abnormalities and hypertension. Just a word about Turner's and metabolic association, it was very interesting. X chromosomal disorders have more proneness for autoimmunity and altered body composition. This led to impaired beta cell function, which can lead them to type 1 diabetes mellitus, and they lead to insulin resistance, can push them to type 2 diabetes mellitus. To top it, we give growth hormone, estrogen, progesterone therapy, which can also augment this problem with compounded effect of lifestyle. So let us remember that we have to give anticipatory guidance to parents who come, to children who come with problems like Turner's. We have come to the end of this session. So friends, an adolescent life is like walking on a tightrope, and we as guardians, we have to encourage them to maintain a healthy lifestyle. And as pediatricians, our role will be to properly counsel with every visit, proper use of local language. When we talk their language, they understand us better. And let us keep it short and sweet instead of endless advices which they don't like. be very clear and assertive, and use appropriate handouts. As Dr. Ranjith pointed out, use pictures, use even your mobile slides, what you have, and articles from magazines to explain your point. And more importantly, be an active listener with open-ended questions, and being non-judgmental and empathetic is very, very important to maintain a rapport with our adolescents. Thank you so much for this patient hearing and this opportunity. I thank my panelists for making this a very, very interactive and enlightening session. Thank you. Have a great day.
Thank you for the superbly delivered discussion, which was lucid and crisp. May I now request Dr. Jayasri to hand over the mementos to Dr. Jeya, Dr. Lakshmi, and Dr. Ranjith